Hi, my name is Hilda. I'm a student of Universidad Católica Santiago Guayaquil, and today I'm going to share with you an interesting topic, which is preserved renal allograft function and the PD-1 pathway inhibitor Nivolumab. Definition: what is PD-1 pathway inhibitor? PD-1 is a protein post-immune control found in immune cells called T. Normally acts as a type of switch that helps prevent T cells attack other cells in the body when binds to PD-L1, a protein in some normal and cancer cells. Immunotherapy is the use of drugs to boost a person's immune system so that it recognizes and kills cancer cells more effectively. Several types of immunotherapy can be used to treat kidney cancer. Applications in medicine. It is important to know that the checkpoint inhibitors used to treat cancer don't work directly on the tumor at all. This only removes the brakes on an immune response that has begun, but has not yet been working at full power.
Let's talk a little more about our immune system and how it works. Taking a look inside our body, all of us are born with an immune system that acts like the security checkpoint at the airport. Our immune system is like a high-tech full-body scanner system that protects us from things that are harmful. In the immune system, T cells have receptors that scan cells to distinguish between normal cells and abnormal cells, like virus-infected cells. Once detected, abnormal cells are attacked and removed by T cells. T cells also identify these cells for future recognition. The same T cells also play an important role in protecting us from cancer. Cancer cells are normal cells that have mutated. The more mutations cancer cells have, the more easily they are detected. Until recently, we didn't understand why T cells were detecting these cancer cells, but not destroying them. But on a closer look, we've made some revealing discoveries. We've learned that one of the ways that cancer cells get past the security system is with the help of a molecule called PD-L1 that is found on the surface of cancer cells. PD-L1 is almost like a disguise that allows cancer cells to remain undetected. PD-L1 basically hacks the T cell scanning system by jamming the signal to parts of the T cell system called PD-1 and B7-1. Think of PD-1 as a sensor that's part of the T cell scanning system, and B7-1 is like an alarm that issues an alert when something is wrong. When PD-L1 hacks the system, it prevents it from doing what it's supposed to do. In other words, it may prevent T cells from destroying cancer cells. Scientists have been working on fixing this problem and have designed molecules to target the PD-L1 PD-1 pathway. You can think of cancer immunotherapy as kind of like a software update for your immune system. Early studies suggest that by targeting the PD-L1 PD-1 pathway, T cells may be able to detect and destroy cancer cells. Let me show you in more detail. T cells have receptors that allow them to recognize cancer. Cancer cells can prevent elimination by turning on PD-L1. PD-L1 deactivates T cells by binding to PD-1 and B7-1. Blocking PD-L1 from binding to PD-1 and B7-1 could prevent PD-L1 from communicating with them. When this happens, T cells may finally be able to respond and kill cancer.
Pros and cons. Pros: there's a drug that targets PD-L1, a protein related to PD-1 that is found in some tumor cells and immune cells. It's called Nivolumab and functions by blocking PD-L1, can help stimulate immune response against cancer cells. These drugs have been shown to be helpful in treating various types of cancer, and new types of cancer are being added as more studies show they are effective. Cons: side effects of PD-1 inhibitors can include tiredness, cough, nausea, itching, skin rash, loss of appetite, constipation, joint pain, and diarrhea.
Most kidney cancers don't have any symptoms, but the most common one encountered is blood in the urine. But it may not be apparent, it may only be detectable on a laboratory test. When the kidney cancers get bigger and more advanced, they can cause pain in the back or a palpable mass in the abdomen. Today we tend to find cancers smaller and smaller in the kidney because we're getting so many scans when patients go to the emergency room. or their primary care doctors. It's very common to order CT scans or other abdominal imaging for things such as abdominal pain, which is often from different causes, such as causes as simple as constipation. So we end up, with all these scans we're getting these days, we end up finding more and more of these tumors that grow very slowly and are very small and would have never hurt the patients within their lifetime. This would have been something that the patient died with, but not because of. Meaning half of all renal tumors that are diagnosed these days meet our criteria of what we consider small. Under the size of 2 centimeters, the chance of these tumors spreading are so low that it's safe to follow them without knowing the subtype of whether it's a cancer or whether it's benign.
Issue apply in Ecuador. Nivolumab are drugs that attack PD-1, a protein in cells of the immune system called T cells that normally help prevent these cells from attacking other cells in the body. In our country, they are used and have given good results. Conclusion: it is an excellent option in treatment of many types of neoplasias, and you have an even more promising future against cancer. It is expected that the future will lower the cost of production and can reach more places and be able to be used.
Every year, nearly 90,000 patients undergo a kidney transplant worldwide. Following the first transplantations in the 50s, allograft survival improved tremendously, with the graft surviving longer and longer. However, there has been no improvement in the survival rate over the past 20 years. And today, 20% of patients lose their new kidney within 5 years of transplantation. These patients must be put back on dialysis whilst they return to the waiting list, hoping for a new transplant. So we need to extend the survival of transplanted kidneys. To achieve this, patient monitoring after transplantation should be improved, with an individualized understanding of the graft evolution and a personalized treatment. At the Paris Transplant Group, we investigated this by learning from historical records of more than 7,000 patients. For each patient, we collected more than 50 parameters, including histopathological, clinical, and biological data. And among those, we identified 8 parameters in our model that are able to accurately predict the graft survival. We have computed these parameters into an algorithm named iBox. For each transplanted patient, we are now able to predict their probability of graft survival at 3, 5, and 7 years ahead. The iBox has been tested on an external cohort of 4,000 patients and in 3 additional randomized clinical trials. The iBox risk prediction score has been proven to be highly reliable for patients, male and female, from Europe and the US, from different ethnic and social backgrounds, from different allocation systems, covering distinct clinical scenarios, and with different treatment. The iBox is the most validated score available